Since Scarlett wasn't at the beginning of the previous session, let me explain the Virtua item again. Today, you received an email from Virtua about the documents and necessary measure that you need to prepare. First, if you want to communicate with Melissa at Virtua, please copy me to have the record of this communication if you want to follow up if there is any problem. And also, uh, for now, you don't need to prepare all the documents that are mentioned, like a background check or different documents. Now, only focus on the medical aspect, the vaccinations, the lab test, on anything that is mentioned there about the medical conditions. I will talk to the university about all these documents, and um, some of them must be prepared by me or by the university for you. And if you need to prepare anything, I will let you know, okay? So now you don't need to prepare any document, only focus on the medical aspect. Um, and I'm not sure if you have any problem with the vaccination, please let me know. Today, I want to discuss a major topic in orthopedic surgery, which is bone healing. Everything you do in this field about the bone is about bone healing. If you design a plate, you are helping bone healing. So you must know how the bone heals. When you want to design a plate or nail, you must know how to design it to help the bone, correct bone healing. When you design an implant and the implant is inserted inside the bone, there must be a bond between the implant and bone. And this bond is formed by bone healing mechanism. Uh, and if there is a failure in the device, actually it is a failure in bone healing. So this is a basic concept, and you must know it in detail to be familiar with different mechanisms and different concepts in it and how we use it. And since bone healing is a physiological mechanism, like any other physiological mechanisms in our body, sometimes it may be slow or it may be delayed. That is why we need to augment it. So let's see what we do. Uh, Bone healing is a complex process. It has several steps and several forms. Not all bones heal the same. Each type of bone healing has several steps, and it is highly regulated. The intrinsic mechanisms inside the body help these steps to move forward. And if it is not necessary, we intervene to augment them. First, let's move back and have a look at the bone formation, not bone healing. The bone formation in our body begins in embryonic life. When the embryo is being developed, different tissues and organs start to develop. One of the organs is bone. This development and creation of new bone continues until the end of puberty, when the growth is finished. After that, new bone is not formed normally in the body. After puberty, the bones remain the same. The only thing that changes in the bone after puberty is its density, its content, not the shape. The content of the bone, which is its density, increases after puberty until the end of the third decade, around age of 27 to 30. After that, so the highest bone density in almost all normal people is around their 27 to 30 of age. After that, it begins to decrease. At first, the decrease is slow, but gradually, after the age of 40, it increases. And in women and men, it is a little bit different due to hormonal changes during the menopause. The decrease in density in women accelerates during menopause, but in men, it doesn't happen, but still in both of them, it continues to decrease. And after the age of 60, almost all men and women have some degrees of osteoporosis. Osteoporosis means decreased density of the bone. So the highest density and highest amount of bone in our body is around age 27. If we can increase it, it will help us, because when it is higher and it gradually starts to decrease, reaching the threshold for osteoporosis will happen later if we can increase the peak of our bone density. So if somebody is younger than 27, that person still has time to increase the density of the bone. And the best way to increase the density is a combination of diet with fresh vegetables, dairy, and enough amount of sunshine. And the last one, but the most important one, exercise. The exercise is very important to reach to peak mass of the bone, and it is very helpful. It was an extra point for you because I know you are younger than 27 and you have time to increase your bone mass. I didn't have this information before the age of 27. When I was informed about it, I was in orthopedic residency, and I was around 29, and I didn't have time to do it. During the bone formation in our body, during embryonic life, two mechanisms are responsible for creating the bone. Still, I am talking about creating the bone. I am not talking about bone healing. These two mechanisms are endochondral and intramembranous ossification. In other words, all the bones in our body are formed by one of these two mechanisms. Very simple. In endochondral ossification, we want to, the body wants to form a bone. First, a cartilaginous model of that bone, which is very smaller than the final bone, is formed. And then gradually this cartilage and the cartilaginous cell inside it transform into bone cells. And gradually they develop a complete bone. So a cartilaginous model turns into a full-blown bone. It passes through different stages, but in intramembranous ossification, we don't have any cartilaginous model, just some primary cells, primary stem cells in the embryo, or in our body, we still have some stem cells. Those stem cells gather in a single area, they proliferate, and then gradually, instead of turning into cartilage and then cartilage turns into bone, these stem cells directly turn into bone cells, and then a full-blown bone is created. Most of the bones in our body are formed by endochondral ossification. Now, the bone has formed, but there is a trauma, and this trauma causes a fracture. Now we need bone healing. Bone healing happens by two mechanisms, primary or direct, secondary or indirect. They are completely different. They happen under completely different conditions, and they pass through different mechanisms. Primary bone healing happens like when you force two metals together. These two parts may have cold welding and they attach together. It is a direct attachment between two metals together. Primary bone healing is something like this. When there is no gap between these two sides of the fracture, and the bones, the fracture surfaces are attached directly to each other, and there is no gap between them, and also there is no motion between them, then direct or primary bone healing happens. Since they are attached together, no callus will be formed, and the resulting bone has the same shape as the original bone. It only happens in some specific conditions after our surgical intervention. When we fix a fracture and we compress the fracture site against each other, fracture surfaces against each other, two conditions may appear. There may be a gap larger than 1 millimeter at the end, or a gap smaller than 1 millimeter. If it is larger than 1 millimeter, no primary healing will happen. Primary healing will happen only if the fracture gap is less than 1 millimeter. This is the first condition. The second condition is if the strain at the fracture site is less than 2%. If the strain is more than 2%, primary bone healing doesn't happen. So we must have two conditions together for primary healing to happen. Fracture gap less than 1 millimeter and fracture site strain less than 2%. Either of these two conditions, if either of them is absent, primary healing doesn't happen. We have, again, two mechanisms for primary bone healing: contact healing and gap healing. If now we are talking about the gap less than 1 millimeter that primary bone healing wants to happen. If this gap is between 0.1 millimeter to 1 millimeter, in other words, 1/10 of millimeter to 1 millimeter, gap healing happens. The name shows there is a little gap. If the gap is less than 1/10 of a millimeter, 0.1 millimeter, then contact healing happens. Actually, the fracture surfaces are in direct contact. Contact healing, as you see here, there is less than, we consider it less than 1/10 of a millimeter gap. So the surfaces are attached together. It happens usually happens with dynamic compression plates. In this mechanism, you remember this image. This is the structure of the bone. The cortical bone has some parts called osteon, which are formed by concentric lamella. Consider this a fracture surface. This is the other one. When we compress them together, these osteons come into contact with each other. This surface with one of these surfaces. Now, the healing process that happens here is called osteonal remodeling. The osteons wants to remodel, to join each other, because they are in close contact with each other in less than 1/10 of a millimeter. Some we discussed before. We have in bone, we have osteoclasts, which resorb the bone. We have osteoblasts, which secrete or create the bone. And we have osteocytes, which are dormant bone cells inside the hard bony tissue. So in bone healing, osteoclasts and osteoblasts become active. First, a group of osteoclasts passes from one side to the other side and create a hole or a channel. And osteoblasts follow this osteoclast and fill this channel like an osteon, layer by layer. So at the end, one osteon is formed from one side to the other side of the fracture site. And it happens at several layers. Many osteons are created, and the fracture is united. The union happens. These small units formed by osteoclasts at the head and osteoblasts following them is called cutting cones. They cut through the bone and create the osteons. Now consider the cutting cones start like this and penetrate the other one. In this way, the osteons join together and a primary bone healing without any need for remodeling happens. But you may say, okay, that's perfect, but we don't like this because it is very slow. And it takes a lot of time to happen, so we must keep the limb protected during this time, but we want to allow the patient to walk fast. So that is why we don't like this type of union, and we don't like this type of fracture fixation. This is another image of a cutting cone, osteoclasts, osteoblasts that are forming the new bone layer by layer. And you see there are several layers of the bone, exactly like an osteon. And these are the osteocytes. Osteocytes are the osteoblasts that are trapped inside the hard, bony tissue. Gap healing happens when when we have a strain less than 2%, but the distance between the fracture surfaces is between 1/10 of millimeter and 1 millimeter. It is less than 1 millimeter. As you see in this mechanism, instead of the cutting cones to create the attachment between two surfaces, the osteoblasts start to lay the new layer of the bone on the surface and continue it layer by layer and create a connection between these two surfaces by transverse layers of new bone. You remember here, the osteons were along the length of the bone. So here, if it is the bone, the osteons are in this direction as my pointer. But the new bones, the new layers of the bone are laid perpendicular to these osteons. When it happens and the fracture gap is complete, again, the cutting cones from the osteons that are present in this direction along the length of the bone start to do the same thing as contact healing. These cutting cones cut through the layers of the new bone and turn these transverse layers into osteons. And again, a primary bone healing happens with creation of the new bone with the same structure as the original bone. And as you see, the bone is directly laid in both methods, both in gap healing and in contact healing. We have no cartilage, no soft tissue, no granulation tissue. Directly bone is laid down. As I said before, we need strain less than 2%, which means we need rigid fixation, which happens with DCP plates. We need anatomic reduction. The reduction must be perfect. The fracture surfaces must be aligned perfectly. And we need adequate blood supply. But again, gap healing is also very slow, even slower than the contact healing. And it is not good for us. So we need another types of healing that is faster. That is why we changed our fixation method from DCP to nailing or to locking plates, which provide more strain between 2% to 10%. And this strain at fracture site promotes gap healing, secondary healing. And this secondary healing or indirect healing is what we need because it is fast, it is stronger, and it is more physiological. When we have a strain between 2% and 10%, secondary bone healing happens. We don't have any primary bone healing. So it doesn't matter if we have rigid fixation or we don't have any rigid fixation. When the strain is more than, irrespective of the amount of gap, when we have a strain between 2% and 10%, secondary bone healing happens. It is much more frequent. As you see here, there will be an extra callus formation. So the diameter of the repair site is larger than the normal bone. And it means that it is stronger for the time of the healing. And also it is much more faster than the primary healing. So we have a union at the fracture site very sooner than the primary healing. Here you see along the length of the bone, we have some vessels, arteries and veins that pass through the canals. And they are tiny, but they carry the blood along the length of the bone in the cortical bone. So when the bone fractures, actually these blood vessels are ruptured. This is the first step of secondary bone healing. Rupture of these vessels causes bleeding in the fracture site. This bleeding leads to inflammation. Inflammation brings some cells, attracts some cells, which we call inflammatory cells. These inflammatory cells release some molecules we call cytokines. These cytokines stimulate the stem cells, which are called to the location. These stem cells can induce angiogenesis, producing new vessels, angiogenesis. And also they can stimulate producing the new cartilaginous cell, chondroblasts. When it happens, new vessels appear in the area, brings blood, nutrition, and oxygen here. And also some of the stem cells, mesenchymal stem cells, convert into chondroblasts. These chondroblasts form some areas of cartilage, a small cartilage, gradually they join together and form a soft callus. Now the fracture site is stable to decrease the pain, but it is not stable to tolerate the load. This is the time when the pain goes away because the fracture doesn't move with the patient movements. But if the patient wants to apply load on it, it will fail. This is called soft callus, and it is soft tissue here, cartilage and fibrous tissue. But gradually, the same mechanism as endochondral ossification happens here, and these cartilaginous particles turns into bone. And this time we call it hard callus. And gradually it becomes strong enough to allow the patient to walk on it and apply load. But still it is not as strong as the original bone because it is, although it is bone and it is called hard callus, but it is woven bone. It is a bone without any lamella, and it is homogeneous. Gradually, under the applied load on this bone, this woven bone remodels and turns into lamellar bone. And this is the final stage. And the fracture unites. After the union, gradually over maybe based on the age, maybe several years, this callus that was formed here and changed the shape of the bone is remodeled completely into the normal shape of the bone. This is a comparison between two types of the bone healings. You remember when we discussed the comminuted fractures and we discussed the breech plating, we said when we have segments in our fracture sites, we don't want to approach it and reduce it in place. Instead, we use a breech plate or breech nail to bypass the fracture site because we don't want to detach this segment from its vascular supply. When the vascular supply to this segment is intact, it is alive. So for healing, it needs to heal through these fracture sites. And when the healing happens, everything is perfect. But if we detach this segment from its vascular supply, we have a problem. This segment will die. And now it will act like a bone graft. It is not a normal bone anymore. It will help the union, but it behaves like a bone graft, like here. Here you see we have a defect here. We need to fill it to help the bone for union. So we use bone grafts and fill the area. These bone grafts are not alive. They fill the area, they have a live cell, but they fill the area and help the union, but it's different from keeping the vascular supply and allowing it to act like a normal bone. Let's see what happens when this segment dies or when we use the bone graft. Something called creeping substitution happens. If we have a dead bone in the fracture site, or we use bone graft, or we use bone substitution material, a mechanism called creeping substitution must resorb the dead bone or the bone graft and allow the body to replace it with new bone. At the end, the whole dead bone or bone graft is resorbed and nothing is left, but the location is replaced by new bone. That is how bone grafts and dead bones and bone substitutes work in our body, by a mechanism called creeping substitution. There is no union. If it was to be a union, the interface between bone graft and the natural bone, the normal bone of the person, must unite. But it doesn't happen. The body attacks this dead bone or the bone graft, resorbs it, and replaces it with new bone. This is called creeping substitution. It has several stages. First, the dead bone or the bone graft or bone substitute is, because it is a dead part, it is attacked by osteoclasts. It is resorbed. The material in it is released. These materials are minerals. The minerals will attract the bone cells, and gradually, as they are resorbed, the new bone cells attack the area and begin to lay down new bone. And after that, the vascular invasion happens and a natural bone is formed here. And the area is fully integrated into the bone. This is called creeping substitution. Whenever we have a dead area in our bone, this process must happen. And that is the problem we have with bone grafts, with allografts, with bone substitutes. We said with bone healing, everything is perfect, but bone healing happens in a live bone. But when we use bone graft, they are not alive. When we use bone substitute, they are synthetic, they are not alive. So this is the problem. First, they must be resorbed and then replaced. And sometimes this process is not what we want, because upon resorbing, the structure will be lost. When the union does not move forward correctly, it can be called delayed, it can be called non-union, or it can be called malunion. Very briefly, I explain them. Like here, you see the union after 3 to 6 months. We expect all the fractures to unite after 6 months in our body. So if by 6 months there is no progress in fracture union, we call it delayed union. And the most important reason for this delay union is our technique. Either we have disrupted the vascular supply to the fracture site during the surgery, or our fixation technique is not adequate. So we have to revise our technique and get the fixation and get the union. the nail has been exchanged for a larger nail, and there was an osteotomy here, and everything is perfect at the end. And if we don't see any union by the end of 9 months, we call it non-union. We don't expect it to unite anymore. And the fracture site is painful. And usually, if there is no fixation, there is movement between the two sides. Again, the most important reason is our technique and sometimes infection. And malunion means the union has happened, but the alignment is not correct. And as you see, this one is different from this leg. It's because the alignment is not correct. The fracture is united in angulation in both planes. So we need to correct it. So if we need to augment bone healing, we have to use one of these options, either a bone graft or bone substitute or a growth factor, stem cell, biophysical stimulators, and gene therapy. Growth factors, stem cells, and gene therapies are under investigation. They are not in clinical use yet. We will discuss them in another session. But today, we are going to discuss what is accepted as an augmentation for bone healing, which is biophysical stimulators and bone grafting. These two techniques are in common use, and there are many methods for them, and we will discuss them briefly. Bone grafting means adding something to the fracture site, grafting bone. Adding something to the fracture site to stimulate the healing process. This can be taken from the patient bones, or it can be taken from another person or another animal, or it can be synthesized in the lab. Bone grafts work by 3 mechanisms. They either cause osteogenesis. It means they produce new bone. To produce new bone, they need to have bone cells, alive bone cells. So the only bone graft that has these alive cells is the bone graft that is taken from the patient's body during the surgery, because they are still alive, because we take them from one side of part of the patient and graft it in another part during the same session of the surgery. So they are still alive, and they are from the same patient, so they produce no problem. This is the only way to have osteogenesis with bone grafts. Another mechanism is called osteoinduction, means inducing bone formation. The bone graft can induce the surrounding bone of the patient or stimulate them to increase their capacity to produce new bone. Osteoinduction is something that happens through molecules, specific molecules we call cytokines. These molecules are not present in all bone grafts. They happen to be present in some of them, but if they are present, they increase the capacity of the union in that bone graft. Osteoconduction means providing a vessel, providing a site to accept the new bone. Remember here, we have some defects. If we leave these defects empty, there is no place for new bone to be formed. That is why we need something here as a scaffold, as a vessel to hold the new bone in place and let them turn into adult or mature bone. This capacity to provide a scaffold or vessel for new bone is called osteoconduction. Osteoconduction is the major function that bone grafts do. They provide, especially the synthetic bone grafts, only provide a scaffold for new bone formation. The rest is done by the patient's body. Bone grafts can be autografts, allografts, xenografts, synthetic, or composite. Let's see. Autograft, the name shows. They came from the patient, the same patient. They are the best grafts. They are the only graft that have the capacity of osteogenesis because they have bone forming cells that are alive and they can form new bone without relying on the surrounding bone. But they have two problems. First, you must take them from another site in the patient body. For example, I have a surgery on my forearm and I need bone graft for my forearm here. You cannot take the graft from the above or below bones. You have to go somewhere else, around the shoulder or around the pelvis. So for a forearm or for a leg surgery, you have to perform another surgery on another site of the body to take grafts. So it increases the surgical time, increases the surgical injury, and it is painful. And the second problem is I don't have so much extra bone in my body. If you need a lot of bone grafts, I don't have so much bone. So the amount of autografts is limited. So we need something else. The second source is allograft. It's the bones from other people, like the kidney, liver, heart, lung that we transplant to other people. We can use their bones for transplant, but there is a difference. When you transplant kidney or heart or lung or liver, you have to use immunosuppression to decrease the interaction between the proteins in the kidney or liver or lung of the donor and the recipient. But in case of allograft of the bone, we don't have this problem because the cells inside the allograft are already dead. And the proteins can be washed out and we don't have any problem with the immune reaction and we don't need any immunosuppression. So we can use it easily. The source is unlimited. You can use as much as you want. You can use in any shape you want, but they don't have any living cells. So they have no osteogenic property. So they cannot produce new bone for you. They can only induce new bone formation and serve as osteoconduction, osteoinduction and osteoconduction, but they don't have any osteogenic capacity. And also, since they come from another person, the risk of disease transmission is higher. Xenograph is the bones from other animals, usually bovine or porcine, but they can induce some immune reactions, but the major problem is because the minerals and collagens present in between animals are different. The integration and incorporation of these allografts in xenografts into our bone structure is a little bit delayed and difficult. That is why we don't use them. But what we use very extensively is synthetic bone grafts. Synthetic bone grafts are synthesized based on the structure and anatomy of the bone, microscopic anatomy, I mean. And with these bones, synthetic bone grafts, you have unlimited source of bone grafts, but the problem with them is they don't have cells inside them, so they don't provide osteogenic property, and they usually act only as osteoconductive. A few of them provide osteoinduction property, but most of them are only osteoconductive. They don't provide any immune risk. They don't carry the risk of this transferring the disease. We have several types for them. One of them is calcium-based. One of them is bioactive glass, and the other one is polymers. You know, the mineral in the bone is calcium-based, and it is hydroxyapatite. They have been able to extract hydroxyapatite, and in the lab, they have been able to create hydroxyapatite crystals similar to that in the bone. And we now we can use that hydroxyapatite as a bone substitute. Wherever we have a defect, we can use that crystals, as you see, like small or large cubes, and put it in the defect. It is osteoconductive. It has a little osteoinductive property, and it is slowly resorbed and replaced by creeping substitute. As you remember, all the bone grafts, autogenic bone graft, allograft, xenograft, synthetic bone graft, all of them, when put inside the body, they undergo creeping substitution. First, they are resorbed, and then new bone is replacing them. Another one is tricalcium phosphate. It is different from hydroxyapatite. Again, it is osteoconductive, but it is resorbed faster than hydroxyapatite. So when it is resorbed faster, it means if we want to use it for support, it is not good because it is resorbed fast. If we want the bone graft to be used as mechanical support, we need to use something that is resorbed slowly. And also it must have good mechanical properties. TCP does not have good mechanical properties. It breaks under load. Biphasic calcium phosphate is a combination of TCP and HA. And the good thing is, by changing the ratio between HA and TCP, we can change the mechanical property as we want, or the resorption rate as we want. And in this way, we can have the most appropriate bones substitute that we need. I am sure you are familiar with plaster of Paris for casting for fractures, the white casts that were traditionally used for fracture immobilization. That white material is calcium sulfate, called plaster of Paris. And it can be used as a bone substitute, as a synthetic graft, and it is resorbed very fast, and it is osteoconductive, and it is very cheap. So if we need a fast absorbing material as bone graft, calcium sulfate is the best. Bioactive glasses are silicate-based materials. They are like they are ceramics, and they are bioactive ceramics. They act as osteoconductive, but they also have some osteoinductive properties. One unique property for these bioactive glasses, and the reason why they are called bioactive is this property, is that when they come in contact with biological fluids, they form a hydroxyapatite layer on their surface, and it promotes osteoblast attachment and proliferation. It means osteoinduction. Some of them, there are lots of these bioactive glasses. Some of them have antimicrobial properties, so they are useful to prevent an infection, but they have a major problem, and that's their mechanical property. They are brittle. And if we use them in load-bearing areas, they break easily. We can use some polymers like PLA or PGA and add some osteoconductive materials or even some osteoinductive materials to them and use them as synthetic graft substitutes. But we have a huge problem with these two materials. When we put them inside the body, they are slowly resorbed. This slow resorption is good for mechanical support. When we need mechanical support, these are better than the calcium-based material. But when they start to be resorbed, they produce an inflammatory response. They stimulate the inflammatory cells in the body, and the area will be inflamed, and it is not something that the surgeon wants. We have another ceramic or polymer. It's better to be called polymer. It was a mistake to call it ceramic. Uh, it's polyether ether ketone, PEEK. It is very strong and very resistant polymer. It is currently in use for some devices in spinal surgery, but it can be used as a scaffold for uh, bone graft. It doesn't have any osteoconductive or osteoinductive properties, but we can change its surface by roughening or coating it with some bioactive material and increase its osteoinductive property, or by changing its structure into porous structure, creating osteoconductive properties. It is not resorbable, so whenever we need a permanent load-bearing part in somewhere in the body, we can use it. 2 weeks ago, the first knee implant, the knee implants are usually made of metals, but the first knee implant used uh, made of PEEK was approved by FDA, Food and Drug Administration, for not for clinical use, for research. For the first phase of clinical research, it is the first time that PEEK is approved for a clinical research as a knee or hip implant. And as I said, PEEK is currently in use in spinal devices, especially the something which is called a cage. In spine discussion, you will see we have something called cage, a spinal cage. It is made of PEEK. It is very strong. We fill it with bone graft and we put it inside between the vertebrae, uh, and it can tolerate the weight of the vertebra and compression of the weight between the vertebra, and it is very strong. Why we use synthetic bone grafts? Because they don't have the problems of allografts or autogenous bone graft. They are unlimited, no risk of disease transmission, no immunogenicity, and also we can ask the company to produce, or they can produce without us asking. They can produce in different shapes. So you have, when, for example, you have a defect in proximal tibia, you can have a cubic bone graft that fits that area and you don't need to add anything. But what are their limitations? They don't have any osteogenetic capability because they don't have any cell. Some of them, not some of them, very few of them have osteoinductive potential. And except for PEEK that is very strong, other synthetic bone grafts are very brittle and they are not strong enough to tolerate compression loads. Sometimes we can use different types of grafts, autogenous and synthetic, together to create composite grafts, and Each one brings its positive aspects. For example, autogenous bone graft brings the osteogenesis property and osteoinduction property. Allograft brings the osteoinduction and the large amount of the scaffold. And peak can bring the mechanical stability, and combining all these together can create a perfect bone graft for the area. These are some information about the composite bone graft. You don't, if you like, you can study them. But the next method to augment the bone healing is biophysical stimulator. Actually, you remember when osteocytes are trapped inside the bone, they don't have any function to create new bone. They are there, they are trapped there to do a major function. They act as a sensor inside the bone. They sense any mechanical or physiological changes inside the bone environment. And when they sense it, they inform the osteoblast and osteoclast to react. One of the mechanisms they detect is mechanical forces. And biophysical stimulators are the methods that use these property of osteocytes to stimulate the osteoblasts to produce new bone. When we have, usually when we have delayed union and the union is not moving forward as we want, we use these techniques. There are different techniques. I included all of them here for you, but you don't need to. If you want to work on them, then look deep into it, but just become familiar with them. One of them is low intensity pulsed ultrasound. Electrical stimulation is the next one, pulsed electromagnetic field. And the last one is, but the most common one is mechanical stimulation. The pulsed, low intensity pulsed ultrasound uses ultrasound, but it is low intensity, and the ultrasound is applied to the fracture site. It must be done each day on a daily basis, and it needs several weeks. The way it works is through osteocytes. It stimulates the osteocytes, and osteocytes, when they sense the mechanical forces that these ultrasound waves are applying to them, they transfer this detection to osteoblasts and stimulate the osteoblasts to create new bone. By this mechanism, the fracture starts to unite. Electrical stimulation is another mechanism which can use direct current, capacitive coupling, and inductive coupling. Each one of these mechanisms uses different aspects of electrical stimulation. The first one, direct current, in contrast to alternating current, it uses some electrodes. These electrodes are implanted surgically inside the fracture site. So the first problem with this technique is it is an invasive procedure. And then electrical current is applied to the fracture site, and it stimulates some calcium channels in the osteoblasts. These calcium channels are voltage gated. They open and close based on the voltage applied to them. So by electrical stimulation, we stimulate these channels, and the osteoblasts are stimulated and they produce more bone. But as I said, this is invasive or at least semi-invasive procedure, and it takes several weeks to be effective. Capacitive coupling use alternating current, and it is non-invasive. The electrodes are applied on the surface, and it induces alternating current between the electrodes, and again, it stimulates the osteoblast to create new bone, and it takes a longer time than direct current stimulation. And the last one is inductive coupling or pulse electromagnetic field. They use a power source and the device to induce an electromagnetic field in the area of the non-union or delayed union. And this electromagnetic field stimulates the osteoblast, and the same thing happens here. But again, it is non-invasive, but it requires a long time. Before explaining the mechanical stimulation, which is the most common and most effective one, let me explain a rule in bones. We have a rule or law called Wolff's law in bone. This rule says that when we apply load on bone, bone starts to react to strengthen itself to be able to tolerate the load. As we increase the load, the bone increases its strength. And if we decrease the load, the bone decreases its strength. So it means that the bone is a dynamic tissue that based on the applied load, the mass and the strength of the bone changes. If the load is increased, the strength must increase. How the bone increases its strength? But increasing its mass, but increasing more bone. And when the load is decreased, the bone doesn't need so much strength. So it decreases its mass to decrease its strength because it thinks it is unnecessary to have so much mass because it doesn't need it. This is called Wolff's law. How it works? It works based on the osteocytes. We said the osteocytes are trapped inside the bone, and they are connected with each other through extensions attached together. These extensions are inside a very tiny channels inside the hard bone tissue. Within these channels is filled with fluid. When load is applied on these channels, the fluid senses that load and transfers this load to the extension of the osteocytes. So the osteocytes sense this load. And now they transfer these sensation to the other osteocytes and then to the osteoblasts nearby here. This is called mechanotransduction. When they sense increased loading, they stimulate osteoblasts. When they sense decreased loading, they stimulate osteoclasts. And as you remember, osteoblasts produce bone, osteoclasts resorb bone. So when the load is increased, bone mass increases. And when the bone mass increases, the strength increases. So the bone can tolerate more load. When the load is decreased, bone mass decreases. So the bone doesn't need to tolerate so much load. This is what happens when somebody goes to International Space Station for more than 6 months. Since the gravity is not applied to them, their bone is not under constant loading. So after 6 months, their skeleton starts to lose mass. And that is one reason that they cannot keep the astronauts in the space station for more than 6 months. Some people stay there for longer time, but that is a research project. This is not a routine thing to keep the people for more than 6 months in a space station or in the space. So when they come back to the Earth, for a while, they have to be evaluated to measure their bone mass and to see if they are prone to fracture, they must be protected. This is the result of Wolff's law. Now, we can use the same concept for fracture healing. When a patient has delayed union, we can use load bearing on that bone, but with protection, for example, with cane on the leg or femur, or with protection of the braces on the forearm and arm. We can apply load on these bones and gradually stimulate the osteocytes, but increasing the load on them, but it must be gradual, not to fail the fracture site and the fixation device. So gradually we stimulate the osteocytes, and the osteocytes stimulate the osteoblasts, and they produce more bone in the fracture site. And believe me, among the physical stimulations, electrical, electromagnetic, direct current, alternating current, ultrasound, this mechanical stimulation is the most effective and most productive method. And almost always, if the patient is cooperative and the technique is correct, and we do not fail the fixation device, it always works. Okay? Any question? This was a detailed explanation about the fundamental concept that you must know, bone healing. We have another session about, in the emerging topics, about the new technologies that biomedical engineers use for bone augmentation, like gene therapy, stem cell therapy, and growth factor therapies. We discussed them because they are not under clinical use. They haven't entered the clinics, and they are under investigation. And more importantly, I want to discuss the gene therapy for you and CRISPR technique. I'm sure you have heard about the CRISPR technique for gene editing, but I want to explain the basics of this technique and how it works for you to be familiar, because it is the future of many treatments in biomedical engineering. And in that session, we will discuss those topics. Okay? Any question? No? So, have a great weekend. Enjoy your weekend. And we don't have any session on this Monday. So see you on Tuesday at 6:30. Yes? Correct? Okay. Bye-bye.
Have a good
Have a good
weekend.
day, Professor.
You too. Bye.